going, I'd like to welcome my long-term collaborator, George Vradenburg, founding chair of the Global CY Initiative on Alzheimer's Disease, the Davos Alzheimer Collaborative, and a convener of a Lausanne dialogue. George, thank you so much for joining. Let's just go into the discussion and explore how, even in challenging times, the field of brain health offers a pathway to resilience, positive change, and hope. Let me start by going back to Lausanne 10. Here, the prominent topic was Alzheimer prevention. And we discussed some of the important developments in the field. So what are for you the main takeaways which we can share with our audience? And what is the action plan which we defined around this key learnings?
Well, I think there are two paths. Well, first, Andrea, thank you for inviting me to participate in this important Global Brain Trust dialogue. There are two pathways to prevention, two strategies. One is to find a therapeutic intervention, a medicine or a vaccine that will be able to be administered into populations at a time when they're cognitively healthy, but which has the effect of stopping the progression of the disease, slowing it down, or preventing it. So that requires not only taking the current initial crop of disease modifying therapies, but also introducing them into populations that are preclinical, that are cognitively normal. That is now going on. Both Lilly and Eisai have trials in that regard. But obviously, the premier and sort of transformative and fixed star of how you would get to an ability to stop this disease before you ever get symptoms is a vaccine or an active immunotherapy. Just a word about nomenclature here. There's a concern, I think, about using the word vaccine because it has so many different meanings in so many different contexts. And also because there is a certain vaccine negativism in certain parts of the world, and certainly a hesitancy in parts of the world. So I think the initial nomenclature that will be used here is active immunotherapies. It may mean functionally the same thing, but to a patient population that we don't want to confuse and whose trust we want to gain, I think we will use a more scientifically oriented term, active immunotherapy, at the outset. And so that's one theory of how to prevent this disease. The other thesis and strategy is to intervene early in the course, in midlife perhaps, or maybe even earlier, but at least in midlife, to significantly reduce the prevalence of the risk factors for late life dementia. That includes dealing with metabolic disorders, that is diabetes and heart and obesity, but also changing our lifestyle factors so that we do not excessively drink or we don't smoke, that we, in fact, pay attention to our diet and to exercise. And of course, one of your panelists this morning or this afternoon is Mia Cavapelto, who's pioneered in this field and with whom we're proud to partner. And then there's the combination of the two. Should we introduce lifestyle trials and interventions, metabolic interventions at the same time, so that in fact we begin to engage what will be important to engage in order to get widespread adoption of either of these strategies, and that is primary care, because most places in the world don't have neurologists. They don't have high cost PET scan screening techniques to detect this disease. So we're going to have to rely on primary care. Primary care, it does know how or can be trained up to understand cardiometabolic issues and lifestyle recommendations. It will take us a long time to get them queued up to be able to administer vaccines, but that is the way we should be going. Vaccines and this lifestyle risk reduction strategy.
Yeah, I absolutely believe that it's really the combination, and this is one of the messages which we gave in these dialogues. If you have risk factors in the family, if you have a diagnosis even of Alzheimer, don't give up, because there are already things you can do by changing the lifestyle. And since the beginning of the years, of course, we have now drugs which can delay the cognitive delay. In terms of concrete action, George, as you know, I always like the concrete actions. How is the DAC now supporting programs that can reduce these risk factors by exactly these two paths? On one hand, the pharmacological ones, so new medicines, vaccines. On the other hand, the non-pharmacological one, for example, lifestyle changes, where Mia will certainly give us an update. So how is DAC supporting it? Because I know DAC is supporting, for example, the Finger Initiative.
Well, let's talk about the Finger Initiative initially. We are partnered with them now. And the view is, as they are working now in 61 countries around the world, and we're working in about 30, that we should combine our efforts to get primary care physicians, primary care facing elements of health system in any country, attuned to the fact that they can, by the use of cardiometabolic interventions and lifestyle factors, actually change the course, or at least the risk of this disease in significant ways. And the public health research is showing us that we can perhaps reduce the prevalence of Alzheimer's through time up to 40 or 50%. So that is one major way to do that. But you have to make the intervention inexpensive. You have to make it available through primary care outlets. And so that's exceedingly important. On the vaccine front, we have formed a working group on vaccines because it entails not just the 8 companies that currently have either preclinical or clinical programs in this area, but also regulators from major regulatory agencies, major countries around the world, UK, EMA, the United States, Japan, and probably in the future, some regulatory agencies from large middle-income countries, but also payers. So we have companies, payers, regulators, and of course, my organization basically is patient-centric. So it's all of the key elements that we need. There are some key regulatory issues. How do you approve an intervention in healthy people in the way of a vaccine? And the answer to that question is we've got to make sure that we know the science, and the science is clear that intervening with an active immunotherapy in healthy populations is actually going to work. And importantly, if you're going to administer this vaccine to hundreds of millions of people potentially around the world at risk for the disease, is it safe? And so regulatory issues are critical. And the regulatory agencies, I don't think yet, are persuaded of the science, but they're open to listening to the science and they're open to figuring out how to approve a vaccine. And payers are concerned that, in fact, they pay the cost of getting everyone screened for the potential risk of the disease. And then people get on a vaccine. Well, they stay on the vaccine for the period of time, potentially lifelong, with updated vaccines periodically, maybe annually, eventually. Will they stay on vaccine to be able to actually achieve the cost savings that would be associated with the use of a vaccine rather than some of these higher priced disease-modifying therapies that are currently being approved? So there are regulatory issues, there are payer issues, and of course, health systems. If you go to a World Health Summit, all they talk about is infectious disease and vaccines. We need to get that conversation, as you noted at the outset, shifted to vaccines in cancer and in Alzheimer's and in other chronic diseases of aging.
Yeah, I think you really hit the nail. I think one of the key aspects, in my view, is that we still have to enhance the awareness of people that the earlier you actually intervene with obviously efficacious and safe products such a vaccine, the more successful the onset of the disease can be prevented. And this really brings me to my last question to you. How can we actually effectively shift this treatment paradigm to disease prevention? How can we enhance the awareness, number one, we have products in development, and we're actually in late stage development. And an early diagnosis with 5 to 10 years recognizing the disease before onset is actually possible. So what do we need to do before the first launch of such a vaccine, which can happen in 2028, 2029? So what
No,
needs to happen?
in the United States, we did some political polling in connection with our efforts to persuade Medicare to cover these initial rounds of drugs. And we found that half of the likely voters in 2024, that is 85 million people, half of those, half of the 170 million voters, 85 million, have this in their family or with a friend. So the American people, and I presume this is consistent around the world, know this disease up close and personal. They know it. Some people want to know whether they have the disease or not, and will go to their doctor and ask. But many people say, why should I ask if they can't do anything about it? And so what this initial round of approvals by the FDA and Medicare in the United States means is that people say, well, maybe there is something I can do about it. So I do think that that's opening up awareness, but I think we need to reduce the costs and the ease with which you can get a detection of a cognitive impairment and a diagnosis. And so that entails several things. We have the right tools. Blood-based biomarkers are coming. Digital cognitive assessments are on the verge of being here in the next year or two. I think those particular tests, which are much more accessible than PET scans, much more accessible than what we have today, and don't necessarily require a neurologist. I think that's going to make it easier for people to find out whether they are at risk of the disease or have the disease. Then we have to be able to say, we've got something for you to do. And that's where Mia's work is so important, because in fact, there are things you can do today, as you mentioned just a minute ago. So making people aware, there are things you can do today. How are they going to learn that? They're going to learn that through direct to consumer techniques. They're also going to work it through their doctors, through their healthcare professionals, through their obstetricians, through their gynecologists, through pharmacies. So there are a variety of tools by which we can make them aware of the lifestyle changes that they should adopt now. And in fact, they should be paying a lot of attention to diabetes, obesity, and hypertension, and thus taking antihypertensive drugs and these new GLP-1s, which are effective against obesity and diabetes. So I think there are things now between the new GLP-1, the new anti-diabetic and anti-obese medicines, through the disease-modifying drugs now being approved, and through Mia's work in terms of lifestyle changes, that we ought to be able to get to the American people. And then doctors have to learn this too. It's not exactly as if the doctors are really ready and primed to advise people about all of these potential things that they can do. We need to educate the health system.
Okay. Thank you so much, George. We will come back to quite a few of the points you mentioned. Payers is one of them. But now it's my real pleasure to welcome our next speaker, which is Sans Thakur. Sans is the chairwoman of the Tower Capital, serves on World Economic Forum councils, and has dedicated her career to shaping and leading initiatives related to generational investment and women health. And how well does that match our interest? Thank you, Sans, for being here. I would like to bring George also in this discussion, but the first question actually goes to you. I was very impressed yesterday when we discussed what your initiative, your fund is doing. And maybe you can just summarize very briefly what Tower Capital actually has in mind when it comes to women's health and generational health. And of course, what interests me in particular, how your experience, how your interests could potentially also overlap with what we want to do. We want to enhance women's brain health, because this is the aspect which is affecting 70% of the women. And so I'm sure there are points where potentially we can do things together, but first, please speak about your excellent initiative.
Thank you, Andrea. It's a pleasure to be here. We at Tower Capital believe in economic development, and we believe that there is no generational health without women's health. So generational health is genetics, epigenetics, and environmental impacts that transcend generations, first, second, third, to fourth, to fifth. And primarily, women are the carriers of this change. They're the transformation agents, as we like to say, in change and in long-term healthcare. What we do in Tower Capital is look beyond the labels of women's health and disease, and we evaluate and understand what are the critical innovations that must be supported, funded, and researched that enable the support of women's health longitudinally, community health, and reduce environmental toxicities that will challenge the shape of our evolutionary curves. And we do this in three ways because we believe all funding vectors are critical for this impact. The first is via economic development, as I mentioned, which is the corporates, the privates, and some government support with regards to funding. The second is via the nonprofit vehicle, which is leveraging charitable donations, works with governments and other large endowments. And the third is via the fund vehicle, so that we can encapsulate and garner the investment support of large investors and large communities of investors towards this purpose. We don't believe brain health stands alone. We do believe it stands inside of us as communities and women, and we are empowered to change that together.
Thank you. As I said, highly interesting. But obviously, when you think about Alzheimer and how it is sort of located in families over generations, we don't even understand exactly. To date, it's not genetic, it's some other aspects. So for me, one important aspect of this generational health, and for that matter, women's health, would be, in fact, to look or prevent, we preserve the brain health. So how well is this represented in the Tower Capital initiatives? I have to push you a little bit.
Very important question, and actually a very critical one to even understanding the scope of generational health. Generational health is not just defined by what's in our genes, of course. A vector is environment. As we know, even and the NIH has reported, in infancy, genes account for less than 25% of variation in cognition, whereas the family environment accounts for approximately 60%. So in addressing early access to care to the most important and underserved communities, addressing this inequity means funding it at a community level and at a maternal level in a way that may have significant longer-term impacts to cognitive health than we ever can understand. Inequity at birth is a generational problem, and health access and financial access is a longitudinal one, which unfortunately is highly inequitable and long-standing. So as part of our strategy in our investment thesis, we identify, fund, and research at the preventative and early stages those innovations and those investments that are going to address both the familiar, the caregiver support, and access requirements necessary for mental health, the biological health, as well as brain health.
George, let me come back to our common concern right now. So actually the science is now progressing. We have the first two approved products. We have vaccines which are safe and potentially efficacious. So how do we deal with the payers and the financial sectors to bring them back to invest, in fact, in the prevention aspect of Alzheimer's? How do we bring this back on the table? How do we work with them?
Well, the payers actually have invited themselves now to our work group on vaccines because they are going to ask themselves the same question. there are a variety of sources of capital in this space. In COVID, we learned that capital can come from governments, capital can come from business, capital can come from investors like Tower Capital and others, and public investors in pharma, and capital can come from payers who pay for the medicine. So there are a lot of sources of capital. They all have to work together. A phase 3 trial in an active immunotherapy is going to be $500 million or more.
Wow.
That is not something that a venture capitalist is likely to do on their own, but mostly likely to tackle, but team tackle maybe with government, maybe team tackle with pharma, but in a way that in fact investors can make money, but it's a high risk venture. And then of course, payers may pay for the vaccine, but there are a lot of costs that have to be borne by industry or by private sector players or by philanthropists, as Sans has said, at big time. So I think this is going to take a combination of capital sources from government, large foundations, and investors, as well as pharma.
Sans, we want maybe to add something to George, what George said.
I agree with George. It's a multi-vector strategy. It has to be one that enables both short-term high-risk investment as well as long-term more stabilized investment. One of the things that we are currently ideating around is a broader cooperative that can invest in highest unmet need categories such as this, which essentially can remove a little bit of risk over time and remove optionality to participate. So we have to look at multi-vector and more creative models of funding that can overcome some of the short-term and short-sighted interests of some of our stakeholders.
I think this will be the discussion certainly we will need to have over the next months and even years. But we don't have so much time. And I'm almost speaking George's language. How do we get this vaccine to the world by 28, 29? Can we take any of the learnings of the COVID-19 initiatives where everybody was forced almost to work together? It was a infectious disease. It was threatening the world, but actually Alzheimer in terms of mortality is almost bigger. So what can we do? How can we put this pressure on governments to actually believe and act on the need to move the timelines and work together, and not just tomorrow, but immediately today? So what needs to happen to get this pressure on everyone to change what we have today?
Sans, you want to go first? You go first this time.
Sure, certainly. So I will pull also from my previous leadership experience with a company called Medical Inc., which offered a digital clinical trials platform heavily utilized across many countries for COVID-19 vaccines. And what I can tell you is that first and foremost, we have to have a little bit of faith in technology. We are in a different world. We were able to run hundreds of clinical trials, less than 12 weeks, cutting costs across millions of patients with political latitude because people were willing to take a risk on technology at a most difficult time. But what we have learned is that that is possible. So with appropriate management and readiness, we should, number one, start to consider those novel ways of applications and thinking about how we can do so at scale. Second is data. Data is quite poor and it's quite siloed across countries. We cannot collaborate and support the needs of a global vaccine without releasing this data and sharing it. And we know industrialists don't often like to do that. So how do we make that happen? And then, of course, third is clarity on policy and regulations. There have been a number of new policies that open gates for different methods and methodologies, protocols for us to innovate together. But these require far greater clarity for us to adopt. So talking about them and ideating them is important and is happening. But the adoption of these new policies has not yet happened. And with that, I hope to see greater change.
George.
I agree with everything the Sans said, but we did have the benefit in a very perverse way with an infectious disease that people are scared as hell and huge numbers. And that puts enormous political pressure on politicians and policymakers to respond. We don't have that sense of an emergency yet. So part of it is making the case that this is a therapeutic area, a brain health, brain disease, is as great as, if not greater than COVID in terms of its suffering, the impact on women, the impact more generally on society. We have the data to make that case, but we haven't persuaded politicians yet. So we're now working with Congress, which has been bipartisan support of increases in investment to enlarge the authorities of our global health community inside the United States government to begin to potentially fund global mechanisms in Alzheimer's, as they have with respect to infectious disease. Now, of course, the government partnered with Gates Foundation and the Wellcome Trust and large foundations to do that. And that's the strategy that we have to pursue here. But we have to create that sense of emergency, sense of size of problem, and the sense of suffering and impact on peoples more generally, but also particularly on women, because they are 2/3 of the cases around the world, that can bring forth the political power to actually change politicians' sense of this is as important as an infectious disease, and the solutions to it can mirror what we've done with infectious disease and engage primary care facilities around the world to administer a safe and accessible mechanism like an active immunotherapy or vaccine.
My last really closing question to you, Sans. What would you recommend us, the Alzheimer community, the women in this community, to move forward and to make preventive measures available as quickly as possible? What would you do? Of course, seeing this from a much more global perspective. Give us your advice.
I think that we have to purposefully act to invest. Funding is the root cause problem ultimately. And I think the second is the rising burning platform, as George was trying to articulate. Women live longer. We have an aging population, and we are going to live longer at a much decreased quality of life. And we all should be stating that very clearly and taking active roles in investing in this long-term area of brain health, as well as in generational health. There is very little chance, given the stagnating and slightly declining rates of global productivity over the next 30 years, that without women and without women's active participation in politics and investment and in telling their stories, that productivity will increase. We are more than half the population. We will guide the genetic code and evolutionary curve. And without our mental health, brain health, and physical health, the future is just not possible.
What a statement. Thank you so much. Thank you both for this quite interesting discussion and leaving us with lots of thoughts.